All right, guys. Well, thanks for logging in here this morning, and hopefully we have a couple interactive talks. I'm going to be talking a little bit about imaging and renal colic. I chose this topic basically because it's something we see commonly. And, you know, I found myself oftentimes reaching for a CT without necessarily doing the appropriate amount of clinical decision-making to determine if that was the best imaging modality to use. So, you know, today, hopefully for objectives, we can just review the basic imaging modalities that we can use when working up patients with suspected renal colic. And I'd also like to get a little interactive. I do have a survey, and hopefully people can participate with that either on their phones or computer, just to see kind of what our practice patterns are in our department. And then I want to talk a little bit about some recent literature and what their suggestions are in particular, and what imaging we might consider in certain patient populations. I'm going to get started with a couple cases. And you guys can see my slides all right?
Yeah, they're good.
Perfect. Okay. So the first case is a 24-year-old female. She presents to the emerge with 2 days of intermittent colicky flank pain, no symptoms of UTI, no fever, no bowel, and no gross hematuria. She had her period, started her period 7 days ago, but she hasn't had any bleeding for 2 days. And when she comes to the department, you really do suspect renal colic based on her history. You give her some analgesia, and she actually improves with that. Her pain's under decent control. She's a healthy young lady, no history of renal colic, however, no surgical history, and her only med's a birth control pill. So you do an appropriate physical exam, and really there's no significant abdominal tenderness, no CVA tenderness, and it's otherwise unremarkable. You order some baseline investigations. The CBC, lights, abdominal panel are all really within normal limits. The urine, you do note some blood, a few leukocytes, and no nitrates. So I'm going to poll you guys here. So there's two ways you can participate. You can either go to pollev.com on your computer /ColinRouse934, or you can just text ColinRouse934 to 37607. And I've activated the poll now. So you can either, all you have to do is, if you are texting from your phone, text to 37607. And if you would do a CT, you just send A, POCUS B, radiology ultrasound C, or just a plain KUB would be D. So let's see if
Colin, can you post that? Can you post that in the chat, please? That link in the chat.
Yeah, sure. Yeah.
Yeah, I was about to say, Colin, that I'm not going to be able to participate. It's too advanced for me.
Okay. Fair enough. I'll just post the link in the chat. But if you know, it's hard for people to get it online, it's easy just to text as well.
Colin receives $3 for each text.
That's right.
Yeah, right.
Let's see here.
I don't even know how to send this.
All right. Yeah, you can. Jay, okay, Jay, I see you're participating in the box, so that's cool too. If you can't figure it out, I am getting some results, so I think some people have figured it out. But if you can't figure it out and you just want to type your answer in the chat box, that's okay too. We got four results. I like the group participation. I have faith now this can be done.
Colin, remind me, you have to give me a tutorial on this later on.
Yeah, no worries. Just, I don't know, a way to try to make it a little more interactive where we can't actually get together.
I think it's great.
All right, we got 4 of 10, plus someone's answered in the chat box. So why don't I just reveal the answers there just to see what we get, and keep in mind that there's one more question like this, so don't rush to get out of your either website or phone, whichever you're using. All right, so 75% POCUS, so we do have a strong POCUS cohort here in St. John, so I'm not surprised about that. And someone else decided they'd start with renal protocol. So I think, we'll get into which one, is recommended, but I don't think anyone's really wrong in this situation. So I'll just clear that one. Deactivate it. We'll move on to the next. I'm going to do one more case. This time it's a 36-year-old female, 4 hours of stabbing, significant flank pain, no symptoms of UTI again. She's mid-cycle. Feels like her previous episodes of renal colic, so she has a history. And her pain's controlled with some Toradol and morphine. She's also healthy. She did have previous renal colic, and at one point with one of her episodes, she had lithotripsy. However, her most recent episode of renal colic was just uneventful, and she passed the stones on her own. Physical exam, vitals within normal limits. Chest is clear, abdomen soft. A little bit of right-sided tenderness, but no rebound, no guarding, and just some mild right CVA tenderness. Investigations, really everything comes out clear here. There's no abnormalities, including her urine dip. However, interestingly, she said on her last, the last time she had stones confirmed by CT, she also had a completely normal urine dip. And this is exactly like her pain that she's had with her previous episodes of renal colic. So I'm going to activate this poll here and see if there's any differences in your approach and what you might choose in this patient. So same thing, you can go either online to poll AV/Colin Rouse 934, or you can just answer your text in the same way you did previously. Or you can just put it in the chat box too. Yeah. Yeah, Tracy, I agree with your comment that there may be some bias based on the people that can figure out how to text.
I feel like I'm on a TV show.
Yeah, exactly. All right, so we got our 4 tech savvy folks that have responded again. I was hoping, we might get 5 or 6 that could get it sorted out, but that's okay. And we got some people responding in the chat box to me as well. So I'll just reveal the responses. Yeah, so we're seeing a lot of POCUS and some CT as well, kind of similarly to our previous response. I think we will have to do an analysis afterwards to see if there is bias based on the people that responded, but we'll see. All right. So I'm just going to do a brief review of the imaging modalities, their sensitivities, specificities, and kind of pros and cons now. So start with the most basic, the plain film KUB, kind of a poor sensitivity of 57%, the specificity up to 76. The touted advantages are there's low radiation exposure when compared to CT, so 0.15 millisieverts, and running people of the millisieverts scale, basically it measures a radiation dose, and it is cumulative over the lifetime, and the studies have shown that the lowest dose that is thought to be related to any malignancy is around 100 millisieverts. So obviously there's not a ton of exposure, and it's less than probably the baseline environmental exposure that you get in a year. It's also low cost, about 10% the cost of an ultrasound, which ultrasound is also less expensive than CT. But the disadvantage is that it's a single view. You may see a stone, you may not, particularly the cystine and struvite stones are poorly visualized, and then the uric acid and matrix stones are not visualized at all. So you're going to be missing stones on these patients. And then we look at ultrasonography. This is radiology performed ultrasound with a sensitivity of 45 and specificity getting higher, around 94 for ureal calculi, and 45 and 88 for renal calculi. So the advantages described in literature are that even if you don't see stones, if there's hydronephrosis, it's a surrogate for a stone that's actually causing obstruction. So something to keep in mind. And it's also radiation free. So this is probably the ideal modality in people that are pregnant, obviously, or, younger age, where you're trying to avoid that cumulative radiation exposure. And then the disadvantages that are often discussed are that it may miss other diagnoses like AAA, appendicitis, pyelonephritis, or a nephric abscess and stuff like that. Now, CT is obviously considered the gold standard. And oftentimes I think when we think of the gold standard, we just automatically say, okay, that's a test we should do because it's the gold standard. But we'll talk a little bit more about that. Sensitivity is 95 and specificity is 98. So, I mean, you're not beating that with any other test. The advantage is you get to see stones as well as the surrounding anatomy. And you're also able to identify those other causes of abdominal pain that we discussed. It's also more technically easy in obese patients compared to ultrasound, but it is twice the cost of an ultrasound. And if the patient's getting a traditional CT, they get 10 millisieverts of radiation. And if they're getting a low dose CT, it's defined as having less than 3 millisieverts. So pretty big difference between those two. When we look at POCUS, sensitivity around 70%, and I realize that that's higher than the radiology ultrasound. And I think that just reflects the POCUS literature is newer and more up to date. And I think just ultrasonography has probably improved over time. And then the specificity, 75% for calculi. And I think the important point here is that the specificity is almost approaching CT when there's moderate or greater hydronephrosis. So like I said, even if you can't see the CT, if you can't see the stone, if you're seeing moderate or greater hydro, then your probability of a stone causing that hydro, given a clinical picture of renal colic, is very high. So I think that's a key thing I learned through doing this kind of review. The advantages for us, obviously, it's something we have at our fingertips. We can use it 24/7. We don't have to hold the patient overnight for CT or anything like that. It's relatively quick to perform. I think everyone's pretty comfortable just doing, a renal exam, from being a part of our, fast exam. We can get a decent look, and although we might not be able to see stones, and there's probably some operator, dependence on the quality, I think most people will be able to pick up like really bad, moderate or greater hydro. So, and I think that's the key point. And the disadvantage, obviously, there's low sensitivity. So just because we don't see a stone doesn't mean there's not a stone there. However, if there's not moderate or greater hydro, the likelihood of it being a large obstructing stone goes down. So it's something to keep in mind as well. So then this came out in 2019 in the Annals of Emergency Medicine. And this was basically the first multidisciplinary, systematic, evidence-based consensus report regarding imaging in renal colic. They reviewed 232 articles, and there was a panel of urologists, emergency physicians, and radiologists that looked at 29 different clinical vignettes. And they did a modified Delphi to try to come to a consensus. And the bottom line of this research basically is that ultrasonography or even no further imaging is appropriate in select patients who present with suspected renal colic. And we'll just go in a little bit more detail about the findings. So basically the main things, they found it's a common problem with millions of annual visits to emerges in the US per year. And interestingly, they found there in the States that in patients who end up with a diagnosis of kidney stone in the emergency department, a CT was performed in 90% of those patients. So kind of looking at our results from a little poll I did, a lot of people were saying POCUS, but it looks as though it doesn't say whether or not POCUS were done, but at least the CT was performed at about 90% of these patients. So that's a really, really high number. And, some of the touted advantages of the CT were that you're going to see these alternate diagnoses. And what the study found also is that these actually only come up in about less than 5%. And, the other interesting thing was, despite increased CT use over the past couple decades, there's been minimal change in the amount of admissions or people that receive urologic intervention, despite the fact that way more people are getting CT'd. And something that surprised me was In the US, and this is data from 2015 to 2016, which looked at 400 US hospitals and over 100,000 patients, only 8% of patients who get a CT for renal colic were given a CT with a low dose protocol. So over 90% of people are getting that 10 millisievert abdominal scan for renal colic when really all they need is a low dose CT. I'm not sure what the local data is for that. I assumed whenever I put in the kind of indication box, query renal colic, and that was really the only thing I was worried about, that patients were getting a low dose CT, but I'm not sure if that's the case. So it's something probably worth discussing with radiology to see what they are doing. And lastly, they noted that ultrasound's unlikely to miss any stone requiring surgical intervention. So if we're not seeing that moderate or greater hydro, even if they have a stone, it's not causing hydro, it's probably small, and they'll probably be able to pass it on their own. As long as you get their pain under control, they may not need further imaging. So how they did their Delphi consensus, they did anonymous voting in 3 rounds and had a group discussion between. And all 9 members of the group were blinded when they answered the questions. And then the a priori consensus was defined as perfect if 9 out of 9 participants agreed. Excellent if 8 out of 9, good with 6 to 7 out of 9, and moderate consensus was 5 out of 9 participants. And consensus was determined not to be reached if less than the majority or 5 people agreed. So, they did have pretty good consensus, which was kind of nice to see. So they either had a perfect 9 out of 9 or excellent 8 out of 9 consensus in over 80% of the vignettes. And although I don't have time to share them all with you today, I really recommend you just browse through them and see what kind of decisions they made. Of note, which I found was interesting, in 45% of the 26 cases, so 13 or 29 cases, so 13 cases, they recommended no further imaging in patients. So that's a good proportion, and you have to look at the vignettes to actually kind of see when they did that. But they're either considering, no imaging in 45%, or just starting with an ultrasound in another 31%. So really, only a quarter of the patients they came to a consensus on that really should get the CT as the initial imaging modality. So I stole this table from EM Cases, who actually did a quick hit of this particular study. And this just basically outlines the first line indications for imaging. And it just sums it up nicely. So when you have a young patient with previous stones and you get their pain controlled and they emerge, and their history is, classic story for renal colic, you really don't have to do any imaging on these patients. So it's kind of reassuring to think of it, it's a young person, they've had previous renal colic, it looks like it, we don't necessarily have to do any imaging at all. And then if there's no history of stones and their pain's controlled, and it's a classic history, consider doing ultrasound alone. And then obviously, as we get higher risk, so like it's uncontrolled pain despite analgesia, it's probably reasonable to get that CT to look for those, underlying diagnoses that may be in the differential. And then as we get to more middle-aged people, if they've had a history and their pain's controlled and it's classic, you can also just use ultrasound. But as we get up into the elderly people, they make it nice and simple. An old person with belly pain, flank pain, differential is broad. These people, we should probably just CT because there's a higher likelihood we're going to catch one of those other diagnoses. I'll just share a couple vignettes of cases to say what the consensus were, just so you guys can get a sense. One is a 35-year-old, no history of stones, presents with acute flank pain for 3 hours, nausea, vomiting, hematuria on urine dip, no abdominal tenderness, pains relieved after IV analgesia. With this patient, young person, no history of stones, they had perfect consensus that point of care ultrasound would be the test to do. And then they give the same scenario, except the patient had 2 previous episodes of spontaneously passed stones, and point of care ultrasound is performed and does show hydro on the affected side, but they don't visualize a stone. And in this scenario, they recommended no further imaging. So in those patients that have a history, they have some hydro, just because we don't see a stone or can't characterize the size of the stone, as long as their pain's under control, we don't necessarily have to get a CT on these patients. We can treat them with analgesia as an outpatient. This patient might be someone that I send an outpatient referral to urology to say, they have some stones, they have hydro, there's no other fever or anything like that, but I'm hoping you could follow up just to make sure that they're passing their stone. And then, if things get worse or pain gets worse, they can always come back and get their CT at that time. But I think it's a reasonable option just to send them home with analgesia and good discharge instructions. And then they give another vignette of that same case, except the patient has no hydro on POCUS. And again, they said no imaging. So the likelihood there is that if it's a good story, previous history, feels like the last time, there's no hydro, he probably has a stone. We may not be able to pick it up on ultrasound because we know we don't see all stones. But it's probably a small enough stone, if it's not causing hydro, that it's something he's going to pass spontaneously. So I would recommend you guys look into those vignettes, and might help guide your clinical decision making. But I'll just open it up to chat now to see what your guys' thoughts are, and if you think any of this information might change your practice, or if you had any other thoughts, I'd like to hear what you guys have to say. Thanks.
Thanks for that, Colin. It's Andrew here. Do you think, have you talked to any of the urologists about those type of situations where they're going to be seen in the clinic in, a week's time and there's no imaging done? Do they want at least an outpatient ultrasound, or is it fair enough that if we make this decision, and we send them to somebody who wants a basic test done that we have in order, it's just going to be slowing things down for the patient?
Yeah, that's a good question. I have talked to the urologist. I find they're actually pretty easygoing about things. Like I had a case a couple of weeks ago with a patient who she has medullary sponge kidney, and she'd had some stones. I think she had some litho, and then she was having some ongoing pain, but it was kind of controlled with analgesia. And I talked to them and they said, you know what, she just had a CT a week ago, we don't need another CT. Let's see if she settles down. We will follow in the clinic, but we don't, we don't necessarily have to jump to kind of re-imaging her. And especially those patients that seem to get recurrent stones, they're just getting CTs so frequently that, we may be opening up the opportunity to cause harm in these patients, and I think we can avoid it. It's great. I haven't really talked to them about a first presenter that we didn't get imaging on, so that would be and usually they're recommending at least an ultrasound. But if it's just uncomplicated renal colic and their pain's controlled in the emerge, I don't know if we have to send every single patient with renal colic, but we think they're going to pass the stone on their own to urology, as long as they have good instructions to come back. And and letting the patient know too that if things don't settle out, even though we only did a point of care ultrasound here today, if things don't settle out and your pain's not controlled with the medication that we're recommending, you should come back and you may need a CT, but it's just might not be necessary today because you get no high risk features that are likely to need admission to hospital or kind of emergent urologic intervention.
I think that's fair, certainly with the recurrent patient. I just have maybe a lower threshold for baseline testing with somebody who's a new patient.
Yeah, for sure. Yeah, that's reasonable.
Ultrasound's the way to go because of in a younger patient and the exposure to radiation. I do the same with biliary colic. You know what I mean? I see the stone on ultrasound, but I send them for a formal because the surgeon's going to be following them up and needs something to some formal report to read. Yeah,
exactly. I think that's reasonable. Even I guess the challenge comes in is when, the young patient comes in and it's, 12:30 at night. We don't have, we could have access to CT, but that's one of those cases where it's, it's probably not emergent if their pain's under control in the emergent, stuff like that. Do we hold those patients overnight to get their CT? Do we send them home to get an outpatient CT? It might be, or just an outpatient ultrasound, right? If it's something we're thinking.
So Colin, on that point, I think you've highlighted something that's quite important here, is that, we do have excellent follow-up radiology.
Right.
And there's absolutely no reason to keep someone around who's younger, whose pain is settled.
Yeah.
There's just no reason to do it. I think
Sure.
we should be doing much more outpatient testing. I do want to ask you though a question. You mentioned the risk of using ultrasound for missing key other diagnoses.
Sure.
There have been a couple of papers on that, and I don't know whether you saw those and whether you want to comment on what the actual rates of miss were when you do use ultrasound as opposed to CT.
Yeah, so it was less than 5%, right? So pretty low. And I think that speaks to the fact that we're just CTing so many people, right? So I think if we're more selective on CTing, you know, the elderly people or the people without a clear history or, you know, previous history of stones and stuff like that, we can probably increase that pickup rate to something maybe like 15% or something like that, you know?
Yeah.
So I think we're pretty safe as long as it's a reasonable story and the patient's young to consider using ultrasound. I think and if we do that, I think the likelihood is even lower than 5%, right?
But then the flip side, and this is just my last question, the study that was actually done from this hospital by urology, we had some input, so did radiology, showed the predictors for requiring intervention do depend on CT scanning. So the size of the stone and the position of the stone were two of the major predictors, along with requiring morphine for needing an intervention. So how do we do that with ultrasound? How do we sort of categorize people who do need to see a urologist versus those who don't? Or are you just advocating that we send them all to urology?
No, I don't think we have to send every patient with renal colic to urology. I think that, like I kind of mentioned, with ultrasound, if they're like, I don't know the specific study of the one that was done in St. John, but they're kind of suggesting with a review of the kind of broader literature that if there's no significant hydronephrosis on ultrasound and you're pretty confident it's a renal stone that's causing their pain, there's low likelihood the patient will need urologic intervention.
There's a lot of studies that show hydro does not predict the need for intervention. A lot. In fact, there's reviews saying hydronephrosis is not a reason for intervention.
Yeah, exactly. But what I'm saying is if you do ultrasound and there's no hydro, then there's definitely no indication for intervention. And in my discussion with like the urologists just on different cases, they don't get too fussed about hydronephrosis. You know, they will follow these patients that do have hydro, I find. If you call them, we'll be like, yeah, just send them, we'll do a telephone follow up, and you know, go from there. But yeah,